by Professor OLUWAFEMI KUTI. Professor OLUWAFEMI KUTI had his undergraduate medical education at the prestigious University of Ibadan, Nsukka, between 1977 and 1983, during which he bagged distinctions in physiology, biochemistry, and anatomy. He had Federal Government of Nigeria Merit Awards for outstanding academic performance in 1980 and 1981 respectively. He also won the Pediatrics Association of Nigeria Award as Best All-Round Student in Pediatrics in 1982. Professor Kuti had his postgraduate training in Obstetrics and Gynecology at the University College Hospital, Ibadan between 1987 and 1991. He proceeded immediately to the United Kingdom, where he acquired vast international experience across different regions of the United Kingdom. He is a fellow of the West African College of Surgeons, the National Postgraduate Medical College of Nigeria, and the Royal College of Obstetricians and Gynecology, England. In tune with his passion for Nigerian women, Professor Kuti returned voluntarily to Nigeria in 1996 at a time when there was mass exodus of medical professionals out of the country. He worked as a senior consultant obstetrician and gynecologist at the State Specialist Hospital of Ondo State between 1996 and 1999, and rose to the enviable position of the Chief Medical Director of the institution in June 1998. He held this position through August 1999, during which period he achieved many developmental milestones for the institution. Professor Kuti joined the services of the Department of Obstetrics and Gynecology of the OBSTETRICIAN University.
And I went through my university education not only without stress, but with some reasonable degree of comfort. I am indeed grateful to my country for this critical head without which I could have dropped from medical school. My going for postgraduate was fortuitous and evidence of God ordering the steps of his children. Despite a brilliant academic performance, I never wanted to go for postgraduate. In fact, I vehemently refused to be addressed professor by my classmate who fondly did so. Being surrounded by many successful general practitioners, I had wanted to finish school and become a general practitioner myself. In our time, going for residency was like sentencing oneself to a lifetime of poverty and misery. At this critical junction, the Almighty God spoke through the only woman in my life, my wife, who to redirect my passion from the pursuit of money to that of knowledge. She simply told me that the pursuit of money has no lasting profit, as most of it will be wasted on frivolous things. She is indeed a pillar of support, a virtuous woman whose worth is far above rupees. My dear, I thank you so much. God will bless you. Although I have the Pediatrics Association Award as the best all-round student in pediatrics, in my 5th year, my interest was swayed to obstetrics and gynecology due to the immense appreciation women and their entire family show following a delivery, especially after treatment for some complications of childbirth. The result of successfully treating a woman during pregnancy and childbirth is particularly gratifying, as most obstetricians will attest. I finished my residency at the University College Hospital, Ibadan in 1991 and proceeded to the United Kingdom for further training in January 1992. Despite the political and economic crisis in Nigeria, I returned from UK in February 1996 against all entreaties to the contrary. 2 reasons informed my decision to come back, despite the awareness of possible economic hardship. The first reason was that I felt deeply indebted to Nigeria. Having been responsible for all my postgraduate training, I therefore considered my stay back in England. I considered it fraudulent. The second reason was that service in England did not attract the same level of appreciation as it was back home. On my return to Nigeria, I took appointment with the then Ondo State Health Management Board in 1996. I ascended along the ranks and became the Chief Medical Director of the State Hospital Ondo in 1998. This appointment gave me the privilege to reorganize the hospital to a standard specialist hospital. By early 1999, I felt satisfied with the running of the hospital within the available limited resources. At this stage, by the prompting of God Almighty, it was clear to me that I needed to serve at higher level. I joined the services of OLUWAFEMI University in 1999. Mr. Vice Chancellor, sir, I stand here today to give a summary of my journey in academia. At creation, the Almighty God pronounced blessing on mankind, asking them to be fruitful and multiply. At the fall of man in the Garden of Eden, the woman was cursed by God when he said, in sorrow you shall bring forth children. In his mercies, the Almighty God has provided a way out of the sorrow in childbearing through the obstetricians. Hence, the developed world has successfully overcome the pains and sorrow associated with giving birth. Unfortunately, in Africa, pregnancy and childbirth still remain hazardous for the woman, where giving birth is like passing through the valley of the shadow of death. Hence, the newly delivered mothers are usually congratulated for escaping the danger of childbirth. The Yorubas will say, Ekwe woman. Mr. Vice Chancellor, sir, I have spent all my academic career to make the journey of pregnancy and childbirth safe, and also to ensure that women are adequately rewarded for their labor by having outstanding children that will fulfill their destinies. Hence, this inaugural lecture is titled, that they will not labor in vain, nor bear children doomed for misfortune. The efforts of an obstetrician and gynecology. You will not labor in vain. This lecture will summarize my efforts in ensuring that pregnancy and childbirth do not end in sorrow, and the woman does not labor in vain. My efforts have been in three major domains: research efforts, institutional and human capacity development, gynecology, the practice, community service. Mr. Vice Chancellor, a woman can labor in vain if she dies or suffers significant morbidity during pregnancy and childbirth, or the babies are unable to achieve their full potential by one, coming too soon, that is premature, or suffering insults in utero, resulting in growth restriction or intrauterine death. My research efforts have therefore focused on reducing maternal morbidity and mortality, and reducing the perinatal mortality. A maternal death is the death of a woman while pregnant or within 42 days of termination of pregnancy from any cause or its management, but not from accidental or incidental causes. In real terms, a maternal death has dire consequences. It is a tragedy of immeasurable proportion. Besides the serious impact on the survival of the living children, the death of these mothers has considerable adverse social, economic, psychological impact on the immediate and extended family, and even on medical staffs. Mr. Vice Chancellor, sir, I will not like to bore this August gathering by recounting the causes of maternal death. These deaths are all well known, as many families who unfortunately have lost loved ones during pregnancy and childbirth can remember exactly the gory stories surrounding the unfortunate event. Many will recall how these women bled or convulsed to death. They will remember how at these critical periods, help was not found as a result of failure in health services or financial constraint. My prayer for you, you will not die in labor. My first observation when I joined the OLUWAFEMI University Teaching Hospital was that most women that died from obstetric complications were not booked or registered for care in our hospital. My colleagues and myself therefore investigated the sources of referral of these patients, the quality of the care they received, and their conditions on arrival, contrary to the common belief that these unbooked patients came from home and were unsupervised in pregnancy and labor. The study showed that almost 60% were supervised in pregnancy and or in labor. Among patients that received care before presentation, the majority, more than 80%, were seen in orthodox healthcare institutions. And more than 70% of these patients were mismanaged. and almost 60% were admitted in poor condition. Can we see tables 1 and 2, please? You can see table 1. Majority of the patients, in fact, all the patients that come from the traditional birth attendants, 100% of them were mismanaged. The next is the mission house. More than 80% were mismanaged. Unfortunately, even from general hospitals, almost 50% of patients that come from them were mismanaged. Can you check table 2? Let's see the condition on arrival. You can see that 80% of these patients from TBA came in very poor conditions. Almost all these patients arrived in the referral centers in very, very poor condition. We went further to determine why the referral centers cannot save these mothers. With a consortium of national and international researchers, we conducted a nationwide prospective cross-sectional study involving 42 tertiary hospitals across Nigeria to assess, among other things, the quality of emergency obstetric care in referral centers in Nigeria, which are the patient's last hope for survival. Quality of care was determined by the availability of definitive treatment and intervention, and the estimated time interval between diagnosis of complication and the initiation of this definitive treatment and intervention. Definitive treatment/intervention was defined as the most crucial intervention required to actually end or reverse the underlying pathology process and avert death. In this study, more than 90% of these patients, in fact, received the required treatment and intervention. There were, however, long delays before administering the treatment. In almost half of the patients, delay was more than 1 hour. And in fact, over 4 hours in 20%. The consequence of this delay was horrifying. 4 of every 10 cases of severe maternal complication will not survive. That is, they will die of their complication. This study showed that timely use of effective interventions are required to improve the outcome of emergency care in our tertiary hospitals. With a very slim chance of survival when women develop complications in pregnancy and childbirth, we embarked on a series of studies to address the conditions that make them vulnerable to complications. We call these risk factors. Prominent among these risk factors are gram multiparity, anemia, and being unbooked. Gram multiparity is defined as a woman who has had 5 or more deliveries. After 5 deliveries, the uterus is at high risk of rupture in subsequent pregnancies. Let's see if we don't want. This woman has 6 children and is pregnant with the 7th one. She's a kind of gunpowder, almost ready to burst. That uterus is already very flabby and can rupture even in pregnancy or during childbirth. In order to have an informed basis for counseling such mothers against pregnancy after deliveries, we investigated mothers' reasons for yet another pregnancy after 5 previous births. The 3 most frequent reasons were desire for more children. The second one is mistake, and the 3rd one is gender, as seen in table 3. You can see that in table 3. While desire for many children is a reflection of the high illiteracy rate in the community, as found by Professor Harrison, our very, very senior teacher in 1989 in Port Harcourt, getting pregnant by mistake suggests unmet need for contraception. Although more than 90% of women were aware of contraception, only 7.8% used them. We therefore carried out a prospective study to determine the level and the reason of the unmet need for contraception among Nigerian women. What our study revealed, an unmet need of 59.4%. Table 4 above. Table 4 showed there are reasons for no usage of contraception. If you read through this table, many are simply what? They are afraid of using it. Only 7.9% of non-users claim not to have knowledge of family planning, confirming that exposure to family planning education does not translate into improved practice of care, practice of contraception, as long as they remain afraid of the method. To assess the high unmet need, we worked on the provision of a more physiological and natural method of contraception, the lactational amenorrhea method. LAM stipulates that women who are still amenorrheic and exclusively breastfeeding have less than 2% chance of pregnancy during the first 6 months of postpartum. Clinical trials of LAM not only confirmed the efficacy of LAM, but also found that the method improves uptake of modern contraception at the end of the 6 months period of protection. We studied the breastfeeding practices and menstrual patterns of nursing mothers in our center to determine the possibility of using LAM in our community and develop a community-based LAM promotion program. Our studies show that more than 70% of our nursing mothers breastfeed exclusively for 6 months or more, and more than 60% of those breastfeeding exclusively breastfeeding remain amenorrheic during breastfeeding. We have since incorporated LAM in our antenatal and postnatal education for our mothers. Anemia, defined as hemoglobin concentration of less than 11 gram per deciliter or PAC7 volume of 33%, is a significant predisposing factor and cause of maternal mortality in Africa. In a cross-sectional study, we found a high prevalence of 62.2% among our antenatal population at booking. Studies have shown that iron deficiency anemia accounts for more than 60% of anemia during pregnancy. We conducted a randomized control trial to compare the efficacy and safety of parenteral iron with oral iron in the treatment of moderate iron deficiency anemia. A significantly higher percentage of patients in the parenteral group had their anemia corrected within 6 weeks with no significant side effects. We therefore recommended parenteral iron for the treatment of cases of moderate anemia before 32 weeks. Before this study, most doctors are afraid to use parenteral iron because of fear. Since we've conducted this, many are freer to use it. Any visitor to the labor ward in Nigeria will be greeted by the uncontrollable shouts of laboring women in agonizing pains, in sharp contrast to the serene ambience of labor rooms in the developed world. This is in contrast to the traditional belief that our women are stoic. That is, they don't feel pain when they are in labor. We therefore conducted a prospective study to assess the perception of labor pains among our women and to determine their need for pain relief. The study showed that almost 70% of women describe the pain as very severe. Only 5.3% perceive it as mild. In fact, more than 80% wanted the pain relieved. We recommended that adequate attention be paid to effective obstetric analgesia in order to make delivering in our health facilities a delight, thereby attracting more women to orthodox facilities for delivery. For the provision of safe, effective, and affordable analgesia, we conducted a double-blind randomized trial to compare the safety and efficacy of pentazocine and tramadol. These are the two opioids that are widely available in Nigeria and that have very minimal side effects on pregnant women. There were no significant side effects seen with either of the drugs, and both drugs produce modest pain relief, which compares favorably well with the level of pain relief reported for petidine in the literature. Overall, pentazocine produced better pain relief than tramadol in labor and was therefore recommended as the first-line analgesic in laboring women. Besides making labor a delight, we must be able to guarantee the safety of the mothers through the prevention and treatment and effective and prompt treatment management of complications. Prominent among these complications are prolonged labor and primary postpartum hemorrhage, that is bleeding after delivery. Poor progress in labor, if undiagnosed, can lead to major obstetric complications such as obstructed labor, puerperal sepsis, uterine rupture, postpartum hemorrhage, and fetal death. The pathograph, a graphical representation of progress in labor, is routinely used for early recognition of poor progress. Use of the pathograph, however, requires skilled personnel, and many of our women, as we found above, still labor under unskilled personnel who find the pathograph technically difficult to use. In the principle of thinking globally and acting locally, we conducted a study to find an alternative means of early recognition of poor progress in labor. that can be used by all levels of birth attendants and even the parent and her family. In a retrospective study of 297 women with uncomplicated singleton pregnancy admitted in spontaneous labor at term, we determined the duration of labor and compared the duration in those who had normal progress as determined by the pathograph with those who had poor progress. More than 80% of multigravida and more than 70% of primigravida deliver within 12 hours of onset of labor. The mean duration of labor was 8.8 hours for primigravida and 6.67 hours for multigravida. The average duration of labor can therefore be used as a proxy for the alert line in the parotograph. In the alert line is what signals that the mother should be referred to higher centers. Birth attendants who are not proficient in the use of the pathograph can be advised to refer patients to secondary or tertiary centers if not delivered within 8 hours of onset of labor, which is the mean duration of labor. The study showed that all parturents, and as most mothers here will find out, were able to recall the time of onset of regular labor pains. The patients can therefore request for referral to highest level of care if they do not deliver within 8 hours of the onset of labor pains. This is, you have to save yourself. With a randomized controlled trial, we confirmed the safety and efficacy of amniotomy, that is breaking the water, in reducing the duration of labor as against leaving the fetal membranes intact till the second stage of labor. We recommended routine amniotomy in patients with uncomplicated spontaneous labor to accelerate labor, thereby averting prolonged labor and its complications. When induction of labor is required, the service must be ready for labor, that is ripe. We conducted a randomized controlled trial which confirmed the safety and efficacy of misoprostol, which is a synthetic prostaglandin E analog, as a cervical ripening agent. The study also showed that the superiority of misoprostol over intracervical Foley's catheter with no difference in maternal and perinatal outcomes. Before this study, what is usually used is the Foley's catheter. Mr. Vice Chancellor, sir, this was a landmark work that led to a paradigm shift to the use of misoprostol for the pre-induction cervical ripening in many centers. The study continued to be widely quoted by scientists the world over and contributes level A evidence in review articles. In another randomized trial, we established the most efficient way of increasing oxytocin infusion during induction of labor. This study showed that geometric increase of oxytocin significantly reduced the induction delivery interval without increase in cesarean section rate or uterine hyperstimulation. Primary postpartum hemorrhage is a major cause of maternal death, mortality. This is when a woman starts bleeding immediately after birth. This is a terrible thing. The uterus can bleed itself out within 5 minutes of delivery. With the discovery of misoprostol as an oxytocin agent, we conducted a randomized controlled trial to compare intramuscular oxytocin with oral misoprostol as oxytocin agent in the third stage of labor. The study confirmed the efficacy and safety of oral misoprostol in the prevention of PPH. We have since introduced oral misoprostol as oxytocin agent in the active management of labor. This intervention has led to a significant reduction in the incidence of PPH in our center. Because of its ability in room temperature, an oral route of administration, misoprostol, is now widely used in peripheral hospitals for this purpose in many low-middle income countries. Only 39% of delivery occurs in our health facilities. This means that more than 60% of our mothers still labor in unorthodox facilities. One major reason for not patronizing the hospital for delivery is the fear of cesarean section. Not only because of perceived cost, but mainly because of perceived risk, but mainly because of the cost. Consequently, the population cesarean section rate in Nigeria is 2.1%, which is far below the World Health Organization rate of 10%. In fact, the hospitals, some country has a cesarean rate, population rate of 25%. Most of our women run from it. In order to encourage higher uptake of this life-saving procedure, we conducted randomized controlled trials to improve technique, reduce morbidity, and the cost of the procedure. The details of these studies are in the book. Mr. Vice Chancellor, sir. These studies, being randomized controlled trials, provided level recommendations and are all published in reputable international journals. They are benchmark studies that contributed to knowledge for evidence-based practice in obstetrics. My research work on reducing perinatal mortality. A perinatal death is the death of a fetus after 28 weeks of gestation. That is stillbirth. Plus deaths in the first week of life. That's neonatal death. Globally, 6 million perinatal deaths occur each year, majority in sub-Saharan Africa and South Asia. We conducted a 5-year analysis of perinatal deaths in our hospital and found a perinatal mortality rate of 77 per 1,000 total births, more than 7 times the rate in developed world. Low birth weight babies, that is babies that weighs less than 2,500 grams, that is 2.5 kilograms. 2.5 kilograms, which constitute only 15% of the total births, were responsible for more than 60% of the perinatal deaths. The study also showed that the rate increased from 74.2% in 1996 to 86% in 2000. Can we show table 5, please? You can see this. It's not relenting. It's just increasing. In 1996, it was 74.23%. In 2000, it became 86%. So we don't know when it's stopping. Improving survival of low birth weight babies subsequently became a major priority of my research. There are 2 types of low birth weight babies. Preterm babies, that is babies born too soon. And the second one is that babies with intrauterine growth restriction, those who suffered insult in utero. A preterm birth is any birth before 37 completed weeks of gestation. Almost 15 million babies are born preterm in 2014, and approximately 80% of these occur in both Asia and South Africa. You can see that majority of the problem in the world is in Asia and Africa. The preterm birth rate in Nigeria is not known, but however, at the OBSTETRICIAN University Teaching Hospital, we found a rate of 12.2%. Survival of preterm birth babies is largely determined by the quality of obstetric and neonatal care services in each facility. Each facility should therefore establish its own gestational age-specific mortality rates. We conducted a 3-year retrospective cohort study to determine the age of viability and the gestational age-specific mortality in our hospital. The study showed that the age of viability in our institution, age of viability is the age at which preterm birth has 50% chance of long-term survival outside the womb. And for our center, it was 29 weeks. No baby, and I repeat, at that time, no baby survived at 27 weeks or less, and only 44% of baby live born, infants at 28 weeks survived, as against 60% and 90% respectively in the United Kingdom. This study, published in the International Journal of Obstetrics and Gynecology, attracted global attention, being the first such study from Nigeria. I was consequently invited to the international conference on prematurity and stillbirth in Seattle, USA, May 2009, as key stakeholder and expert in maternal and child health. I was the only Nigerian academic so invited and one of 9 from Africa. A major cause of neonatal death among preterm babies is respiratory distress syndrome. This is caused by structurally immature and surfactant lungs. Prevention of RDS with the administration of antenatal corticosteroid to the mother has long been used to accelerate lung maturity in babies at risk of preterm birth. Although this intervention is used in developing countries, including Nigeria. No trial has been conducted to confirm the safety and efficacy of this in these settings. A study conducted in 2016 to scale up its use by a man called Arthur and called Act and Act Trial raised serious concern on the safety and efficacy of this intervention in low-middle income countries. Consequently, the World Health Organization conveyed a technical consultation of obstetricians, neonatologists, and researchers in preterm birth to design and conduct a randomized control trial to evaluate the safety and efficacy of ACS in low-resource settings. Mr. Vice Chancellor, sir, I was fortunate to be one of 2 Nigerian obstetricians invited to Geneva for this very important task. We conducted a multi-country, multi-center, randomized trial of neonatal corticosteroids for women at risk of imminent birth in the early preterm period in low-resource countries to improve newborn outcome. We call this study Action 1. We found a significantly higher neonatal death in placebo group, that is, women that did not take the ACS. There was no significant difference between the 2 groups in the incidence of maternal infection. This landmark study conclusively confirmed the efficacy and safety of ACS in women in low-resource countries who are at risk of early preterm birth. And we can confidently say this study can be used in any of these settings in the world. Another major problem of babies born preterm is their inability to control their temperature, leading to hypothermia. They are therefore usually cared for in an incubator to provide safe temperature control and a physiological environment akin to the womb. The kangaroo mother care is a cheaper and natural way of providing warmth and care for preterm babies. It involves continuous skin-to-skin contact of the newborn with the mother or appropriate surrogate and exclusive breastfeeding. Interestingly, this is how kangaroo nurses its babies. I was one of the principal investigators who conducted a large, multi-center, multinational, randomized control trial to evaluate the safety and efficacy of continuous kangaroo mother care, initiated immediately after birth in inverts with a birth weight of between 1 and 1.8 kilograms. The study was conducted in Ghana, India, Malawi, Tanzania, and Nigeria. I wish to tell you that our hospital was the only center taken for this study in the whole of Nigeria. The IKMC babies had lower rate of hypothermia and sepsis and lower neonatal mortality rates at 28 days compared with babies that were nursed even in the incubator. This is a novel work with the potential of saving millions of low-birth babies in low-middle income countries across the world. My work in reducing stillbirths. Pregnancy usually brings joy to a family with a high expectation of having a live, healthy, and bouncing baby. Delivering this potential bundle of joy as a stillbirth is a major tragedy for the parents, as it puts a sudden end to the emotional attachment between them and the fetus, especially in this era of 3D and 4D ultrasound, where you can actually play with the babies in utero. This tragic experience triggers profound grief and significant psychological mobility. Globally, more than 2 million babies are stillborn every year. With a stillbirth rate of 42.9 per 100,000, Nigeria has the second highest rate in the whole world. Despite this high burden of stillbirths and its profound devastating impact, it has not been accorded the global attention it deserves. It is not captured as a target in the Millennium Development Goal and still absent in the Sustainable Development Goal. It is a neglected tragedy. The implication of this tragedy is that mothers' own high aspiration of life born is not receiving global attention. Mr. Vice Chancellor, sir, I was the only Nigerian among the world-renowned international collaborators that wrote the first paper in the Lancet Stillbirth series, dedicated to bring stillbirth into the front burner of global health. In this paper, titled Stillbirths, Why They Matter, we surveyed 135 countries in the world and discussed all all issues surrounding stillbirth, we were able to justify why stillbirth should be a global priority. I am glad to inform you, sir, that this effort, together with that of other stakeholders, have led to the launch of the Global Every Newborn Action Plan in 2014, which provided a roadmap strategic actions for ending preventable newborn mortality and stillbirth, and set a global target for each country to achieve a stillbirth rate of 12 per 1,000 total births by 2030, rather than just leaving it unrecognized. I wish to tell you that the Federal Ministry of Health, who has promised to listen to this message online, launched the Nigerian Every Newborn Action Plan in 2016. So we have joined, and we have started our own in Nigeria. To help us meet the ENAP target, we conducted an audit of stillbirths in our center to identify the causes and risk factors for stillbirth in order to guide us in the development of effective strategies for prevention. For this study, we used a perinatal death classification system, an avoidable factor proforma developed in our hospital perinatal unit. Our perinatal unit classification system, including maternal diseases condition, peculiar to our environment, but not coded in the European and American classification system. Our avoidable factor proforma has 5 major groups, with each of the groups having subdivisions in order to identify the specific cause of delay in receiving care as against the traditional 3 delay system of TADIUS and MEN used all over the place, all over the world. We found a stillbirth rate of 51 per 1,000 total births. Only 3.8% of the stillbirths were unexplained as against 5.7% and 26.4% with the recode and coded system used in Europe and America. More than 80% of the deaths, unfortunately, are judged avoidable, with the most common avoidable factor being deficiency of care, followed by cost and religion. Please, can we look at table 6? Yes. You can see deficiency of care, even among book patients, constitute about 71.4%, and on-book patients is about 41%. Ignorance. But actually, if you look at among on-book patients, cost of care is next to deficiency of care, and after that is religion. So the people cannot take care of themselves because they don't have the money. And of course, religion is an issue. When they don't have the money, they seek solace among our religious, in the religious houses. The most common cause of stillbirth among on-book patients is obstructed labor, while intrauterine growth restriction is the most common cause among book patients, both of which are highly preventable with good antenatal and intrapartum care. Intrauterine growth restriction, can you show me figure 4, please? 4, is the inability of the fetus to reach its genetically determined growth potential, usually due to reduction in nutrient supply. You can see these 2 babies. They are of the same age. Both of them are time. One is so small, the other one is big. This small one, although did not die, but has is going to develop a lot of medical challenges. Is at risk of poor neurological development, high blood pressure, and all problems. And so, it's a big problem. Babies, however, have a coping mechanism to the reduction of nutrients supply to prevent death, fetal death. Preventing fetal death from intrauterine growth restriction requires meticulous fetal growth monitoring to identify when the rate of growth is slowing down at the time when it is slowing down, and Doppler monitoring of fetal blood flow to identify when the fetal adaptation to the reduced nutrient is about to surpass acceptable limit. For the early recognition of intrauterine growth restriction, I pioneered the establishment of a fetal monitoring unit similar to what obtains in anywhere in the developed world. We partnered with the Perinatal Institute, Birmingham, England, to develop the Yoruba customized growth chart software. The software will generate a fetus-specific growth chart after inputting maternal variables such as weight, height, ethnic origin, and priority. Hence, it is called, the name is customized. The chart not only predicts the optimal weight at term, but also shows the trajectory of the rate of growth to achieve it. Prior to now, We just use the same chart for the big one, for the small. But now, we have differentiated it. You can see the chart. Oh, unfortunately, it's not clear. The first baby, the first one has a BMI of 47.8. And the weight of that woman is about 100 kilograms. For this woman, if this woman has a baby that is 3 kg, that baby has suffered in utero. He has suffered growth restriction. And he's not allowed to do that. The next baby, the next chart, is for a smaller woman with a weight of 50 kilograms. That woman can have a baby that is even 2.8 and it will be appropriate for her weight. This tells us that this is how babies should be monitored. So, the customized growth chart enables us to identify reduced growth rate of for prompt management. Once IUGR is suspected, we then perform Doppler velocimetry to confirm the diagnosis and monitor the growth of the restricted fetus to help determine the most appropriate time to deliver the fetus to avert fetal death. This monitoring protocol is particularly effective in preventing fetal death, as abnormal Doppler velocimetry can precede fetal death by up to 2 weeks. Can we show picture 7? This first chart here shows a normal Doppler. You can see that the diastolic flow is very full. When the baby continues to suffer, there will be no more diastolic flow. And in fact, at times, it starts to do the reverse. At that stage, that woman should be delivered. If the baby is not delivered, it stands the chance of what? Of dying inside the uterus. But if we are able to pick it early, we can prevent this death, because this abnormal flow precedes death by at least 2 weeks. Mr. Vice Chancellor, sir, I am delighted to inform you that our perinatal unit has published the umbilical Doppler reference chart for fetal monitoring for this country. With this publication and the development of customary growth chart, we are the only center in Africa that is currently providing this state-of-the-art fetal monitoring. Prevention of mother-to-child transmission of hepatitis B virus infection. To the general public and some medical personnel, mother-to-child transmission only implies prevention of HIV infection from the mother to her baby. Unknown to many, there exists a more prevalent, highly infectious, more wicked viral infection that can be transmitted from an infected mother to her baby. The infection is called hepatitis B virus infection. Hepatitis B virus is a DNA virus that primarily attacks the liver. It is 100 times more infectious than HIV and can survive for up to 7 days after the human body, still remaining infectious. Globally, more than 2 billion people are infected and an estimated 360 million are chronic carriers. It is the chronic carriers that are responsible for the perinatal transmission of the disease and at high risk of developing serious liver diseases, including cancer of the liver. With a prevalence rate of 9.5%, Nigeria is among the high prevalence area of the world, where the major mode of transmission is from the mother to the child, and we call this vertical transmission. The infection becomes chronic in 90% of babies infected perinatally, where it smolders in the liver, relentlessly destroying it and causing serious liver disease that will eventually lead to the death of this unfortunate person between age of 30 and 40 years at the prime of life, you will agree with me, making it a very wicked infection. In conjunction with the Department of Virology of the Nigerian Institute of Medical Research, Lagos, we conducted a prospective study to determine the rates and the risk of perinatal transmission of hepatitis B virus at OBSTETRICIAN University Teaching Hospital. We found a perinatal transmission rate of 72% using the HBV DNA testing of the cord blood. The study also showed that perinatal infection was associated with high maternal viremia. At the time of this study, although we routinely screen all antenatal patients for hepatitis B virus infection, our hospital, like most other hospitals in Nigeria, had no protocol in place to prevent mother-to-child transmission of the disease, despite the high prevalence of chronic carriers. In order to address this gap, I, together with my colleagues in the perinatology unit and the gastroenterology unit of OHUC, developed and implemented a protocol for the PCMTC transmission of HB infection at our hospital. Since the commencement of this implementation, or in the implementation of the protocol in 2015, 364 babies have completed their 9 months follow-up and had their blood tested for hepatitis virus. Mr. Vice Chancellor, sir, I am pleased to inform you that no baby, and I repeat, no baby, are tested positive for the disease. This work is in press. Thank you. It is a common saying that a tree cannot make a forest and a soldier cannot become an army. It is with this consciousness, Mr. Vice Chancellor, sir, that I have ensured the establishment of institutions to fight the menace of maternal and parental mortality in Nigeria. This includes establishment of the perinatology unit of OBSTETRICIAN University Teaching Hospital, establishment of maternal perinatal death surveillance response meeting, establishment of the Association of Fetal-Maternal Medicine Specialists of Nigeria, and training of undergraduate and postgraduate doctors. Perinatology unit. At its inception in 1978, our department was officially named the Department of Obstetrics, Gynecology, and Perinatology. And that was in the wisdom of the founding fathers. For almost 4 decades thereafter, the main activities of the department revolved around obstetrics and gynecology, and the perinatology arm was not visible. I officially established the perinatology unit in 2014 with the aim of providing cutting-edge perinatal care and training in state-of-the-art equipment. Figure 8. That is the perinatology unit. We are currently the only center in Africa providing complete fetal monitoring using the customized growth chart, MPDRS meeting. Our studies have confirmed that infrastructural upgrade and increase in the number of skilled birth attendants do not translate to reduction in maternal and perinatal deaths in the absence of good quality of care. To improve the quality of care in our institution, I started and chaired the Maternal and Perinatal Death Surveillance and Response Committee, where we critically review all maternal and perinatal deaths with the overriding objective of determining the cause of death and identifying many avoidable factors that could have contributed to the deaths. We also recommend actions required to avoid similar deaths in the future. The membership of this group cuts across the departments of obstetrics and gynecology, anesthesiology, neonatology, and community health, and social welfare department. At the inception in department, Association of Fetal-Maternal Medicine of Nigeria, inspired by the impact professional organizations make in reducing parental care. When I attended the conference of International State Birth Association in Birmingham, I floated the idea of starting a similar organization in Nigeria. Many of my colleagues bought into this idea, and it led to the birth of the Association of Fetal-Maternal Specialists of Nigeria, AFEMSIN. The membership of this association cut across the whole country and includes foremost clinicians and academicians in the field of obstetrics and gynecology. I was the immediate past president of the association. We have sensitized the country to the burden of maternal and fetal deaths and proposed ways to resolve the lingering problem through our annual scientific conference. Even during the COVID-19 pandemic, we did a webinar that goes across the world. We have representatives from the federal ministry, from the House, and other stakeholders to discuss how we can accelerate reduction of maternal perinatal death in Nigeria. Training of postgraduate students and resident doctors. Mr. Vice Chancellor, sir, since I joined the university in 1999, I have been privileged to be part of the training of more than 2,000 undergraduate students in the subject of obstetrics and gynecology. I have also supervised more than 20 postgraduate students who are consultants both within and outside Nigeria. As part of my payback to the society, from which I have benefited early in life. I started a self-sponsored, non-governmental organization called Maternal Fetal Organization of Nigeria to address the major obstacles to reducing maternal deaths in Nigeria through advocacy, training of appropriate skilled birth attendants, research, and public enlightenment in radio. The organization has sponsored a lot of activities, including the radio jingles on safe motherhood. Time will not permit me to let you hear one of the jingles that sings, that goes around the whole of Ondo State. And we have also conducted training of local government midwives in fetal monitoring, fetal growth monitoring, as shown in figure 11A. This is where I was giving lecture, and the next one I was teaching them how to use the chip. Currently, we also have an emergency combat at the labor ward of the Ife Hospital unit of OHTC. This provides emergency cesarean section materials that are not immediately available to reduce test stage delay. Some patients come dead in the night. Some of these equipment are not available. We go to Mapego Combat and we can supply it. But some of them return when they have the money. If they don't have the money, we let them go. Concluding remarks. What are the impacts of these efforts on maternal mortality and morbidity? Globally, maternal mortality reduced 45% at the end of the MDG. Unfortunately, in Nigeria, all these efforts and that of my older eminent colleagues have not translated to the expected reduction in maternal and perinatal mortality. In our review of perinatal death in OHTC in 2001, the state birth rate was 52 per 1,000 total births. In a repeat audit in the same institution in 2017, almost 2 decades after, the rate was 51 per 1,000 total births. You will agree with me, we have not made any progress. Then, at the end of the Millennium Development Goal era, WHO placed a verdict of no progress in Nigeria. Not only did we not make progress, we became the world's highest contributor of maternal deaths, overtaking India with a total maternal death of 53,000 in 2015. In the 2019 report, not only did we maintain our role as the world's capital of maternal deaths, we contributed 23% of the global rate. With a total death of 67%, we have improved by moving from 53,000 deaths to 67,000 deaths. India, 7 times the population of Nigeria, came a distant second with a total death of 35,000. Thus, Mr. Vice Chancellor, sir, Mr. Vice Chancellor, sir, is the unfortunate grim reality of the status of maternal death in the 21st century Nigeria. We still have gory cases of obstetric complications similar to that seen in the 1950s. Nigeria is one of the worst places in the world to give birth. Let's see table 7. You can see that sub-Saharan Africa, to give birth a child that is life risk of maternal death, defined as the possibility of the baby dying, 15 years dying from a complication of stillbirth. That was 1 in 37. Chad has a rate of 1 in 15. Nigeria came just after Chad with a rate of 1 in 21. If you compare this even to our neighboring Ghana, Ghana has a rate of 1 in 82. And now, fast forward, compare with the United States of America, it's 1 in 3,000. And in the United Kingdom, is 1 in 8,400. I have the privilege of working in the United Kingdom for 4 years and being part of the management of 7,000 delivery. I wish to tell you that no woman died. But in Nigeria, there's no clapping here, but in Nigeria, every week there is a woman dying. Why is there no change? Mr. Vice Chancellor, ladies and gentlemen, it may interest you to know that 90% of the cases of maternal death are from direct obstetric complications, which occur in about 20% of all pregnancies everywhere in the world, including developed countries. In other climes, however, these complications very rarely lead to death, as I've just told you, because the treatments which have been available for decades are accessible to the people and are promptly applied and efficiently applied. Why then have there been no progress in Nigeria? The simple answer, sir, is that we had employed wrong strategies to address the problem. Programs such as the Integrated Maternal Newborn Child Health, Life-Saving Skills, Task Shifting, and Task Sharing are generic, as they are not solely directed at preventing and managing direct obstetric complications. Other programs, such as conditional cash transfer, implemented in 12 of 36 states of Nigeria, midwife study scheme, implemented in 10% of the local governments in Nigeria, and maternal and perinatal death surveillance and response were patchy, poorly planned, and badly implemented. Many of the notable programs executed by some state governments were not sustainable. What then is the way forward? These are my recommendations. For the accelerated reduction of maternal and perinatal mortality rate in Nigeria, we need to learn from the experience of the developed countries who have been able to rapidly reduce their maternal mortality rate to less than 10 per 100,000 in a short time. Nigerian current rate is more than 800 per 100,000. What they did is they professionalized midwifery, removed economic and geographical barriers to accessing care, and backed this up with an enabling law to make it a national program. Professionalizing care in pregnancy and childbirth is the key success, and that involves the training of enough midwives to make sure that only, and I repeat, only qualified personnel attend all births. Sweden, United States of America, and England use this strategy, and the result is a drastic and rapid reduction of maternal mortality rates within 20 years. In 30 years, Nigeria has not made a progress. The few African countries that have made significant progress at the end of MDG employed strategies that professionalize midwifery care and remove barriers to accessing care. I therefore propose a national safe delivery program that will involve intervention to address direct obstetric complications. Details of this proposition is in the book. The program should use the existing health centers for the distribution of interventions, and the program should be backed up with an enabling law to make it a national program. You don't need to build any new places. We have the places to just renovate and supply the personnel. Conclusion. I wish to tell you, ladies and gentlemen, Mr. Vice Chancellor, sir, that our efforts have generated sufficient body of knowledge, competent personnel, and solid institutions to deliver women and their babies and their families from the agony and tragedy of maternal and parental death, so that they will not labor in vain. Unfortunately, we do not have what is required to make all this accessible to the women. What is this? The political will. With a strong political will, only 3 things need to be done to save our women and take Nigeria away from the unenviable position of being the global capital of maternal death. These are professionalized midwifery care, improve standard of care at all levels of care, make the care of women during pregnancy and childbirth completely and totally free. I wish to repeat this. To make the care of women during pregnancy and childbirth completely and totally free. If the truth has to be said, there is no amount of money that is too much to save the life of mothers in carrying out their God-given national assignment. Men, after all, cannot get pregnant. This is their assignment. What do you think? Do you think there is any amount of money too difficult to save women? I don't think so. Appreciation. Mr. Vice Chancellor, sir, permit me to express my appreciation to some of those who God used to make my academic journey fruitful and fulfilling. I want to thank my teachers at the University College Hospital Ibadan, Professor O.A. Ladipo and Professor B.O. Oshinisi, for their guidance and assistance at critical levels. And I'm happy to inform you they are still alive and they are watching this online. I also like to thank the 2 past chief medical directors of the OHUC, Professors Adejuibe and Adetiloye, for their support for the perinatology unit. But for their support, there will not have been perinatology unit. I thank you, sirs. My immense gratitude goes to all the consultant staffs in the Department of Obstetrics and Gynecology and Perinatology for giving me permission to enroll their patients for research activities. I sincerely appreciate all my national and international collaborators, especially Professor Ebuende Juigbe, the indefatigable neonatologist at OUTC, Drs. Femi Oladapo, Rajiv Bal, Joshua Boje of the World Health Organization and Geneva, and Professor Jason Gadosi of the Perinatal Institute in Birmingham. My sincere appreciation goes to all the patients who voluntarily gave consent to participate in all the studies. I wish to especially thank my wife again, and my children, who not only endured my long absence from home, but functions as my data entry clerks and secretaries on many occasions. They are all great pillars of support. Once again, dear, I thank you so much. And that's the loving woman. Finally, I thank the Almighty God who made this day a reality. He started the good work and has promised to take it to perfection in the name of Jesus. I thank you all for coming. Thank you.
It's a big party. Come on. Let me dance in the rain. Let me dance for the Lord. He's worthy of my praise. He's worthy to be praised. Ora mi open. Ora mi open. Give them food, give them rice. Let them eat plenty wine. Make everybody feel alright. Make everybody feel fine. Ora mi open. Ora mi bajoka. Put all my shame into fame. Put all my money into dancing. Put all my disgrace into party. Put all my yeah.